Open.
Outspoken.
It's ophthalmology off the grid.
An honest look at controversial topics in the field. I'm Blake Williamson.
I'm Gary Wörtz.
Welcome to a new episode of Ophthalmology Off the Grid. Here, Dr. Cathleen McCabe shares two surgical horror stories with Drs. Blake Williamson and Gary Wörtz. Listen to the unique circumstances of these cases and how Dr. McCabe approached these challenges.
All right, everybody. Welcome to another episode of Ophthalmology Off the Grid. We're your hosts, Blake and Gary, just getting back from AAO. Gary, did you have a good time at the conference? I didn't get a chance to see you, so I was in and out quick and you were like arriving and I was leaving. And
that's right.
It's a bummer.
We used the divide and conquer method, Blake. You took half of the people and were able to greet them. I greeted the other half, and I feel like that with both of us together, we saw everybody. So that's all we needed.
And got to spend time with our family when we got back, so that's good. It was a good meeting. I did get to bump into today's guest, the one and only Cathleen McCabe, who this is her 112th time on Off the Grid, which is a record. I think that's a record.
It could be 1,000, and I would just want more.
Yeah, she's our favorite guest and one of our most frequent guests, and it's because she is this rare combination of absolutely brilliant, humble, lovely, and just someone that you want to talk to whenever you see her. And that to me is just, she's one of my favorite people for all those reasons and so many more. She's a brilliant scientist. She's a fantastic friend. She's a great mother, awesome wife. I mean, just has everything to aspire to be. And so Kathy, for all those reasons and more, we are always thrilled to talk to you.
You two of my favorite people in the whole world. Have you say so many kind things is just wonderful. I love being with you.
Wow, they're well deserved. Blake, you know, we're talking this season about horror stories. We've had quite a laundry list, and every time I have a guest come on, it makes me feel a little bit like I'm not alone in the struggle. And
it's Halloween too. It's Halloween too, so it's time to get spooky.
Right.
Get spooky on this episode.
Yeah, and I was almost embarrassed to ask Kathy to come on here because she's such a fantastic surgeon. I was hesitant because I felt like she may not have anything to share, but we're going to dive in anyway. So Kathy, with that, tell those, for the three people who don't know where you're at and what you're doing, tell us about what you're doing at the Eye Associates at Sarasota and a little background, and then we'll dive in.
All right. So it's so good to be here with you guys and right around Halloween talking about horror. So what an honor. But I am a cataract and refractive surgeon on the West Coast, the stormy West Coast of Florida this year with a couple hurricanes that we've just been through. And I've just been around long enough that I have lots of horror to talk about. So, and since you mentioned the kids, and just because we have such a varied audience, I know it's just about every ophthalmologist listening to you guys, as I am too. I just want to say, like, I do have, I have 5 kids. I have 3 grandkids. Some of the things I admire so much about you two is your commitment and dedication, and just how you prioritize your families, and you're all around great citizens and wonderful people, and you just exude that to your friends, and you're just so caring and loving of your families too. So if you're out there and you think, I'm just not killing this with my family, I'm not killing this with what I'm doing in ophthalmology, you just keep doing your best. That your best is the best anybody can expect of you. And when you're giving your heart and your love and your passion to your family and to your career, you're going to kill it. So that's the encouragement for the day before we get into the horror of the day.
I love it. So Kathy, we offline before we started recording, you were recounting some interesting experiences you've been involved with. You take us in whatever direction you'd like, and we will be happy to listen and dig in. So where would you like to start?
Well, let's start with surgery, because I think I remember when I first started out in practice, I don't know if this was like that for you guys too, but I'd be sitting there, especially when we're at the sink scrubbing, which that was like such a big ritual to begin with in residency. Now we just have foam and it's quick. You don't get to sit there and contemplate as long. But I'd be like, oh, please, let me do a good job with these patients. Let me do something that's, improving their health, and I don't have a complication. And I'm thinking through the steps of what I'm going to do, even if it's cataract surgery, and I've done it a few times already. If it's something more complicated and something new, then I'm really thinking about it, right? And I think as you get further in your career, you're not as focused on every single case, like going through that mental exercise ahead of time. So, but sometimes there's a case that comes along and surgery just doesn't go the way you think, or it's way more challenging than you thought that you could handle, no matter what it is in your career. And so I did have a case. I had this gentleman come in who was super, super kind. And I don't really know how, when I saw him in the clinic, it didn't occur to me that he might need some special scheduling because the first mistake I made was he ended up on a normal, very quick surgical slot, just like any other cataract. I was going to go in and whip it out and get it on to the next patient. And he was in the pre-op area and he was laying back as far as he could lay back. And he was his torso was sitting up, looking at me in the face. So he was 90 degrees to the horizontal of the rest of his body. And I was like, well, that's interesting. And my CRNA was like, yeah, that's interesting. And I'm not sure that we can, although I've had lots of kyphotic patients and, patients who can't really move their neck very well, not that they couldn't move their whole torso at all. And so the first thing we did is just say, oh, I'm so sorry. We're going to need to really think about this and, be a little more creative and put you in at the end of the day when we have time to really work on how we're going to position you. And so the clincher was, he said to me, thank you. Thank you so much for allowing me into your preoperative area. No one has ever tried to schedule me for surgery before. And you let me come in here and try to think about surgery. And I am so eternally grateful. Well, at that moment, I knew there was no way I couldn't do a surgery, right?
So the question I have, Kathy, is how many other people had he been to see before you that refused his case?
I don't know, but at that moment, I was 100% certain I was going to do everything possible because, a guy who could be so grateful for the fact that I did nothing but waste his time that day, that's a patient who deserves some extra care, right?
Yeah.
Not that they all don't, but for sure, this guy. And so we did reschedule him on the end of the day. And what we ended up doing is we put him in as much Trendelenburg as possible on the bed. And he's a big, big guy, approaching 300 pounds, like big guy. And so I put another bed underneath the head of the bed that he was in because I thought that there was a chance the bed was going to fail. So I just didn't want all of a sudden the bed failing and him falling on his head or his torso, or whatever part would hit the floor first. So we did that. And then I figured out that, my microscope at the time could actually go from vertical, we're looking down on the eye as the patient lays horizontal. You can actually rotate it enough that it's horizontal. And I'm sitting, the patient who's facing me, sitting up at his upper half of his body. And you can do that. It actually works. The only thing that's kind of weird about it is the oculars are straight out at you. So your working distance is your entire length of your arms. So that's a little odd, so you're at the extension of your arms. You have no elbow that's bent, and you have to kind of figure out how to use that. So for his first eye, his head was a little also tilted down toward the right. So his first eye was his left eye. And because it's his left eye and I'm a right-handed surgeon, it wasn't a big deal because I could have more room for my right hand because my right hand was temporal and wasn't limited by his nose. And so, it was an interesting thing to do. It was kind of everything moves differently when gravity is affecting 90 degrees to what you expect. So even like wetting the cornea, we put some dispersive viscoelastic and it was a glob that was sort of coming down. I had somebody holding his forehead, holding the lid speculum up because of gravity, wanting to bring that down as well. And then the rest of the surgery really went pretty normally. And I got it in the bag and we did high fives. I had to figure out how was he going to do his drops post-operatively. And it was back in the days that we had transonular Trimoxy. So I put that in. And there is something called Simply Touch. It used to be available. I think it still is on Amazon, whereby surface tension, you can put a drop of something on it and hold it vertically and then touch it to the conjunctiva. And so we got him that, so he could put his post-op drops in. And I used Resure sealant, because you can see how old this is. I'm dating this surgery, right? Because we had that
7 years ago-ish.
Yeah, it was like 2016, I think, is
Okay.
actually when it happened. So 7 years. Look at that. 6 or
Right.
7, yeah. So so anyway, that all went great. And he was so happy and thumbs up at the end of the surgery and, just high-fiving and thought the world of what I'd done. And such a delightful guy that, of course, he came back and wanted me to do his right eye. Well, his right eye was a whole different beast because of the way he was positioned, with his chin a little bit down into the right and his nose being in the middle of his face, like most people, was in the way. Unfortunately, I couldn't move it, was in the way of a right-handed surgeon sitting facing him. And so now I had to be even more creative. So now the microscope couldn't just face him horizontally. It actually had to be angled up. And when you put the microscope angled up, you can still look in the oculars, but now they're pointing up in a weird way that you have to hyperflex your neck to look in it. So I do believe I still have some cervical issues from this case.
Seriously.
Because it was a very long case. We redraped him 3 times, actually, because he was exhausted and so was I. And with that configuration, so many other challenges came up. The microscope was sitting on his chest. So every time he breathed, he was moving the microscope as well. And when, in order to have any space for the length of our instruments with his face tilted down, there was only about 3 clock hours that were accessible for the length of even like the diamond blade or the phaco handpiece, because otherwise it was sitting on his chest. So all those things I'm thinking about, and it's working. I'm still getting through it. I pre-chop him because I only have 1 incision. I'm thinking, pre-chopping. I remember I used to do that. And that worked to get 1/2 of the heminucleus out. And then as he's just getting more and more tired, the view is deteriorating. There's lashes in the way. I'm not seeing very well. And the worst of all possible things happened. What do you think?
The patient didn't die.
He didn't die. I didn't die. He didn't die.
You didn't die.
Right. Like, I feel so much better about this case already. It wasn't the worst. Nobody died.
Yeah.
And it wasn't a suprachoroidal hemorrhage.
At this point, I'm not sure what you do next. So I'm going to say option number 2, he didn't die, but perhaps now you've got to deal with an open capsule.
Yes. Oh, of all things, vitreous. So yeah, so I did. My phaco handpiece, phaco tip went through the posterior capsule. And as soon as I saw that lucency, I wanted to do the normal thing we normally do, which is denial. Unfortunately, that didn't work. And I'm looking at it, I'm thinking, at this point, I don't know that I can finish this case. Truly, at that moment, I was like, I don't know. I don't have any additional room there, even to make a large incision to now convert to an extra cap. There's not much space there. The one of the saving graces is when your head is tilted toward the floor and you're operating, nothing falls posteriorly. Gravity is helping to keep it all in the anterior chamber. So that was good. I hadn't lost any nuclear fragments back there. So I actually did sort of like sit back. We took the drapes off for a second so that he could take a break too, because it was really tough on him, the position that we had him in. And I just thought for a minute, like, maybe I should refer this patient to a retina specialist. At this point, maybe I am not the best person to continue this case. And then I thought, who is going to take this case? who is going to take this patient who you really can't position in any way to get normal access to the eye? So I put my big girl pants on. I don't know.
Yeah, but you feel guilty.
pulled my
You
boots
feel
back on.
guilty
Yeah.
referring this to someone, but you also feel like, what do I do next? I mean, Blake, I don't want to like disrupt the rhythm of the story, but Blake, what do you do when you're in a situation where you're just like, I'm not sure, I don't know what to do here.
Yeah, I mean, so for me, I actually do have a low threshold just to put a suture in the eye and refer that to my retina specialist down the street, Dr. Burnham or Dr. Kilpatrick. I mean, they start our worst case scenario, just open capsule and a lens sitting on the back of the eye. That's how they start their cases routinely, and it's just trocars and all that thing. All those things are just second nature, and not to mention, we have a large caseload right behind them of patients who need us to get through the day and take care of them, and so you have to kind of weigh that in mind. And I just don't think I am the best in those scenarios of suturing in lenses and all that stuff. I will say, if I can get a lens in the sulcus, right, that is something that's critical. I think it helps out your retina colleagues so much. If you could just clean up the cortex, and if there's any way you can get a lens in the sulcus, man, that's not, at the end of the day, that's fine. They're probably going to see 20/25, 20/30 the next day, or maybe, a little corneal edema, they're 20/50, whatever. Point is like that saves them having to get biometry. Many retina specialists don't have biometry. But if I deep six a lens or something like that, I don't know. I have a low threshold. Now that's a patient with normal morphology. In this case, it's different because to Kathy's point, it's like, well, this guy, no one's probably going to touch him, and he's just going to walk around, be faking. And so in this scenario, I think you got to keep.
Yeah. So Kathy, sorry to interrupt the story. Tell us. So you decide, okay, I need to move forward with this. How did you break down how you were going to get this lens out without, it was just a lot of viscoelastic and prayer and slow going and lowering the bottle? And what was your approach?
Well, there was still a good half of the nucleus in there, and he had a dense nucleus, because nobody was touching him for a while. So I couldn't just, I had to actually convert to an extra cap. I had to get it out with the lens loop. So the first thing I did was, I do have these more narrow lens loops, which I love, and I use those even on mission trips, so I don't have to make a gigantic incision to do a lens loop.
Did
So
you
I
just
made,
enlarge your corneal incision to like
I
6 millimeters?
yeah, and probably not even a whole 6 millimeters. Yeah. So, but I enlarged it enough for the width of that narrow irrigating lens loop, and was able to get the nucleus out because, again, gravity helped me to keep it in the anterior chamber. There was an intact anterior capsulotomy still. The next thing I had to figure out is, well, I know that you're supposed to separate your infusion from the vitrector when you're doing vitrectomy. So I want to do that, but how am I going to do that when I only had those few clock hours to begin with? And I was able to find like the smallest bridge of cornea and the ability to put a paracentesis in next to it and separate my infusion from the cutter. So I was able to do that and complete an anterior vitrectomy. And so I did do that as well. And because he had an anterior capsulotomy that was complete, I put a 3-piece lens in the sulcus with optic capture. And the worst part, because I just hate suturing, I just hate Tenno.
Thank you for saying that. You're the first honest ophthalmologist who said they hate suture. I feel like everyone loves it, but me, I hate it.
I am there with you with the hatred of the suturing. Yeah,
it's not fun.
Absolutely. Why do you think I developed the flange thing and love that so much? No suturing.
Thank you.
We need three of us need to come get a T-shirt for Asker that says "I hate suturing."
Yes, exactly.
Absolutely.
I'll get it.
You know what I hate more than just regular suturing is suturing when you have to have your neck completely flexed after 3 hours of surgery and your arms completely extended, and you have this really awkward position. So, and I had to put at least 3 sutures in there, so I did. He looked great at the end. He really did. I was really proud of that. But this was the point in my career where I really thought I might have to throw in the towel in the middle.
I want to psychological piece, because I know that you have another case to bring up, but I do want to just quickly just say that, like, I get this sometimes from even my team, and I kind of when I'm in a flow state where I'm just rocking and rolling, and let's say a patient comes in, it's like not 300, but like 500 pounds. I've had a couple people on my team before, like, oh, I'm not sure that they can fit because we have a weight limit on our hospital bed. It may break the hospital bed, and I'm like, well, how do you know? Like, did we weigh them? Like, let's not be so. It's almost like your team, not in an ugly way, but sometimes like just in an efficiency way, when you're very, very busy, they almost like self-select like the more difficult cases that we might want to refer to someone else. And so it gives me a little pause when I feel that from them. And I always kind of push back because oftentimes we're the best people to do it. I mean, gosh, there's not many people doing better cataract surgery than us, in town, in our little town here. And it's the same for you guys. And so I just feel like, Down syndrome patients, I get that all the time. They've been kind of referred to two or three other people. To Gary's point, I don't know why they always got saw three other doctors, and then finally I got here. I'm like, okay, so like nobody was referring to me. Like they're like Blake will do it. But seriously, like I think that we should have a low threshold if they have a real cataract and people aren't helping them. You schedule it on a lighter day. Figure out a way to have a long preoperative informed consent with a family member in the room. Hey, listen, I'm going to try, but this is probably going to take 2, maybe 3 surgeries to get them to the final place, which you and I know we're probably going to get it all in one. But like, it takes all the risk and all the heavy off of you. So I don't know. I just feel like I get kind of I get put in that situation sometimes where my team around me can sometimes make it easy for me to punt. And I'm like, I'm not sure that's the best. I'm just being honest and vulnerable here, but I still think that's the best way to do it. Yeah, I love that you did that.
Oh, I appreciate what you're saying too, because sometimes, and this is exactly what you're saying, the patient who's come to me, who's seen 2 or 3 other docs and they didn't want to do it. And I'm thinking, okay, this is not the most fun cataract surgery I'm going to do on this day. There are some challenges. Maybe there's annulopathy, it's post-traumatic, it's fibrotic capsule, there's a lot of synechia, there's so many possibilities, or dementia, that's a big one too, or Down syndrome, or something very challenging positioning the patient. And I'm thinking, other people have these skills, and yet I get that they didn't necessarily want to do it because there was a higher risk. But I feel like that's where I get the most satisfaction, kind of in a way, of giving back, because this is a patient who really, really needed somebody who wanted to do the hard work. And I think we're obligated to do the hard work. I would want somebody to do the hard work for my loved one,
I agree
or
with
if it
you
was
so
me.
much.
So,
Kathy, it's so well said. I do think that if first of all, it's the old saying, there's no crying on the yacht. We all have wonderful facilities to operate in. We're all blessed with a lot of volume. And so, we sort of, we've got it great professionally. And so, like you said, from the giving back standpoint, I kind of feel like it's my ethical responsibility, given the amount of normal, easy cataracts I'm able to do and have done over a lifetime, that when someone really needs me, that's my responsibility. I don't have to fall on the sword for every patient if I don't think I can take care of them. I mean, that's first and foremost. But if it's just like going to be annoying and going to take a little while, I really do feel like if it's within my skill set, I feel like it's my responsibility as a counterbalance to all the blessings that I've been given professionally. I feel like I need to help. I need to do those cases, and it can be the most rewarding, and the ones that you look back over your career and you're like, you know what? A lot of people could have done the easy ones, but I was really happy that I was able to help these 1% cases that maybe no one else would have or could have done. So good on you for doing that. We've got a little bit more time. So why don't we talk a little bit about your next case? Let's give you other parting thoughts on that one. How did he look post-operatively, and how grateful was he when it was all said and done?
yeah, so he had to go back to the OR because there was no way I could take his 10-0 nylon sutures out any other way. And as you get older, you guys will eventually realize you get more presbyopic, and then things get tougher. That illumination and magnification of the OR microscope becomes even more necessary for things like that. So not just the positioning problem with him. So, but I did take him back. And it was nice because I could get some pictures too, right? To really see how he was doing, because he was not able to position in a slit lamp at all. And he looked great. So I took his sutures out. He was, of course, enormously grateful, said it changed his life. And, just again, the sweetest, sweetest person. And I couldn't be happier to have participated in his care, even though my neck still is not right to this day.
It took its toll.
Yeah.
I'm sure. Well, tell us about this next case that we chatted about just a little bit.
Yeah, I kind of, when I was thinking about the topic of horror stories, I was thinking, like, what are the ones that I really found super challenging, that like weigh on my mind even today, where it's like years and years later from working with certain folks. And I think sometimes the challenges we have are not in the OR. They might be the challenge of the psychology of having to say no to a patient, for instance. And one patient and this patient's family actually really come to mind, because they are a patient, the whole family, which I don't always, because I do a lot of cataract surgery, and often they're for that portion of their care, but not ongoing. But this is a patient that I saw and her family ongoing for quite a while. And she was in her late 40s. She had been, at one point, a PhD candidate in her life, but was living with her parents, and was living with her parents because she had some serious psychiatric issues. And part of the manifestation of her fixation, and sort of a compulsion that she had, was she, somewhere along the line, understood that in your 40s, you start to lose your accommodation. And in her mind, a lot of her difficulties, in fact, all of her difficulties, which were many in doing the things she needed to do to live independently, which she did not, she lived with her parents, she felt were impacted by this loss of accommodation. She had done tons of reading about accommodation, knew the science, she knew a lot of the words, the vocabulary around accommodation. And she understood that there was an accommodative lens, a crystal lens, that would restore accommodation. And if someone would only do her the favor of putting in a crystal lens, all would be well in her life. And she was not willing to see a psychiatrist. She was not willing to be treated for her psychiatric disorder. She was actually kind of a little bit aggressive with her parents, and her parents were elderly parents too. And they, her mom in particular, a lot of times both of her parents came in. Her mom always came in with her, but at times it was both of them. And her two parents were also patients of mine who had cataract surgery eventually. And there were just times that I would talk to them. They would want to talk to me separate from the patient, saying, look, I don't feel safe in the house. We really need to do something. She's just becoming more angry about this whole situation. I can't get her to think of anything else or talk about anything else. And through the years, really, of taking care of them, I was able to get her in with my primary care doctor eventually, because she didn't want to see a psychiatrist, but she eventually did see my primary care doctor, who was then able to get her to a psychiatrist. And she did get on some medication, and she was doing, better with that. And I can say that I've followed up with her in the last 5 years, so I'm not sure what's going on with their dynamic now, but I felt like I had really helped along the way by eventually getting her some of the care she needed. But I would say that whole situation so often weighed on my mind. Like, I just wished there had been a way of me trying to impact that situation even sooner. And
Was she presbyopic, Kathy? Was she actually
Yeah.
presbyopic?
She was. Yeah, she was.
Okay.
Yeah. I mean, not terribly.
So if
but
it's like a late 40 person who otherwise was stable, who just hated reading glasses, when you might actually consider replacement on, but in her case it was different because of her personality and psychology.
Yeah, and I think she might have been a little bit hyperopic, but she had LASIK in the past too. At some point, she had talked somebody into doing LASIK for her, but she knew the next step was not the fact that it was a distance vision problem, because that had been fixed. It was the loss of accommodation.
So this I feel like is an extreme example of something that I run into from time to time, and I think we all do, but I think you have painted a really, sometimes with an extreme example, you can see other situations that mirror this in maybe a lesser way. But I actually have said for a long time, I think a lot of unhappy multifocal or presbyopia correcting IOL patients are unhappy because they have determined, they've boiled down all of their life problems and they fixate on their vision being the source of their frustration. And if they can just have their vision fixed, the rest of their life problems will be solved. And when you solve their vision problems and the rest of their life problems are still present, it unmasks this horrible disappointment that their life is never going to be fixed. And it manifests in them thinking that the lens is not performing correctly or that you didn't help them in the way that they wanted to be helped. But it all comes down to they put an enormous amount of their life hope and their mental, their mental health hopes on a procedure fixing their situation. But the problem is the person you are before surgery and the person you are after surgery is really not that much different. And so I mean, I have definitely seen this before where it's like it's almost like an anger or a depression / anxiety that unmasks after they're not happy after cataract surgery. It seems very out of proportion to what they're seeing from a Snellen acuity standpoint.
That's interesting because the other case that I had actually thought about that's similar to this is another couple that I took care of who the husband, both of them had cataract surgery, but the husband was like sort of this extremely high functioning guy. He was definitely like the financial driver of the family, definitely like, in every way took care of all the details of the family. And he developed dementia over the years that I was seeing them. And the anger that he had around even his vision issue, which was so out of proportion, to what he was going. I think he had some dry eye and some things, but he had a lot of anger that sort of was uncontrolled. And it was really just a manifestation of his dementia. And I think that ties in exactly to what you're saying, that a lot of times vision's not just vision, it's vision in the psychology of the patient. What I tell patients sometimes is, a patient can come in because they'll say, well, my neighbor said they saw great after cataract surgery at distance and near, and they didn't have anything fancy, or,
Yeah,
something
they didn't pay for it and it didn't hurt. It was free and next day.
But I always say, I can walk into a room and somebody can say, Doc, you're a miracle worker. I see like an eagle. Or they can say, gosh, I can't see to tie my shoes. And that gives me zero indication really of what their vision is. Like it could be anything they could be 20/60 and I'm the miracle worker. They could be 20/25 -1 and they can't see to, pull out into traffic. And sometimes there's little correlation between the numeric value of their vision and their perception of vision as well.
Yeah, I think that part of the mastery of refractive cataract surgery, I don't know if I'm there yet. I'm just keep working my whole life to get there. But part of what I've learned recently is like when you have those people post-op that you weren't able to say no to, or that but for whatever reason sometimes you meet the representative on the pre-op consult, you don't actually meet them, and you miss something and you do operate on them. I think part of the key is just to get calmer and quieter, and have your game plan and execute your game plan. And I was not good at that my first few years of practice. I was not quick to explant a lens. I was not quick to do a LASIK touch up for -75 of SIL. I was very much optimize the ocular surface guy. Let me hold your hand and talk to you. I can talk you into anything, right? Let me just talk you into your happiness. And I did it. So I was successful sometimes, but other times I just needed to get the lens out or just do the damn touch up. And so now I realize that, gosh, that's very much a part of what we do. And so now I have my game plan of, okay, what's the refractive error? What's the hard contact lens over refraction? Is it a cornea or is it a lens? Is it refractive error or not? Does the lens need to come out or does it need to stay in? If it does, we'll redo the money. And that's fine. And if all those things, we do all those things and there's still a problem, then we're going to do a vitrectomy. This likely a floater issue. And if you have those 5-6 steps, you're like going to make that 1% or 0.1%, 99% of those you're going to make better, and many of them are actually very happy. And once you realize that, you're like, okay, so that it's just a long road. And Nicole Fram said it best at the refractive surgery conference the other day. She said, she tells her patients in this scenario, there's a journey before cataract surgery, and sometimes there's a journey after cataract surgery. And she says it just like that. And I'm like, man, that's so true. And so I'm starting to steal that a little bit.
Well, I just because what you're saying so true, and it's having that game plan in mind, but you have to overlay that game plan on all the things you've learned about the psychology of patients, because it's like the patient who has their first multifocal or premium lens of whatever sort in one eye, and they're like, I don't know, I'm not totally happy with this eye, right? And so the approach to that patient is psychology influenced a lot, because in one patient, you're going to be the quicker we put the technology in your other eye and you get to neuroadapt, the sooner to happiness. Another patient is going to be, this is a sucky lens for me. We can say that on this show, right?
Yes. We will bleep it out, I'm sure.
Sucky's okay.
Okay. It will never be a good lens for me. You put the wrong lens in. I hate this lens, da da da. And it's already, they're so onto that they will never let that go, right?
Fixated.
Yeah, fixated. So, and deciding which patient you have sitting in front of you in that scenario is all the things you've learned as you've gone through your journey as an ophthalmologist. And, that's where you decide, all right, I'm going to zoom down my other playlist right away, or I'm going to be able to work with this patient and they're going to be patient. We'll optimize their ocular surface. We'll get the other eye done, and they're going to be okay that way. And differentiating which patient is which that's part of the art of medicine, right? That's kind of what we learn as we go along.
Absolutely. And one thing I want to bring up is along the lines of what Blake said. Blake, when you said early in your career, it was you were a little bit slower to intervene when a patient was unhappy. And I was exactly the same way. And probably all of us are. And it was not because it wasn't the right thing to do. It's because I was not certain I had the skill set to do that thing that needed to be done. And it made me anxious thinking about doing it. So there's this old saying my partner says is the patients are how you are. And if you're anxious about doing something, it's going to transfer to the patient. Whereas, like you said, if you can explain to someone, okay, you're not happy right now, totally get it, no big deal. We've got 5 things we can do. We're going to do them in order. 1, 2, 3, 4, 5. If at any point during the process you become happy, we stop. And if you're not happy at the end, we can still reverse the whole process. No big deal. Everybody, goes through this on some level, and we're going to make sure you're taken care of. Don't worry about it. It's just a very different, it's received differently. And so sometimes the horror story is the story we're telling ourselves in our mind, and then that becomes transferred to the patient. And so I think as we learn and mature in our refractive skill set, it also impacts the way we're able to communicate with patients in not just a verbal way, but almost a nonverbal way where they're reading into, am I okay or am I not going to be okay? And ultimately, that's the communication that we need to tell is, you are going to be fine. We are going to help you, and we're going to get you through this whole situation. That there is no shortcut to that. It definitely takes time. And so I wanted to just kind of bring that up.
Oh, I love that. That's such a great pearl for listeners too. It's just feeling confident that you have the skill set and the ability to communicate that to the patient, to confidently let them know you're going to work through the journey, like Nicole says, that happens post-operatively. Like that's such a key thing of next step after you worry about, like we started saying, you're worried about the case before it starts. And then you're not worried about that so much, but you're worried about the management of the unhappy patient. And then when you get confident in that, you allow the patient to be confident the whole journey, the way that they're going to spend that time with you. So
Yes, absolutely.
Yeah, and it's weird with flips where once you get that confidence, the management of the unhappy multifocal patient actually becomes kind of fun. It's almost kind of like a puzzle because you're so confident that at the end of the day, you're not going to have any trouble cutting out a lens that's only been in there 2 or 3. Like it's going to be fine. You can refund their money and get them back at their bifocals, and it's all fine. And it's never not been fine in my limited experience of the past 8 or 9 years doing this stuff. Really only the past 3 or 4, I'm actively feeling confident doing those things. And so it kind of flips all that anxieties. I'm like, now when I hear an OD say, hey, Mrs. Smith is unhappy, golly, I'm like, okay, cool. We'll get her in. Let's see what's going on. I'll even call her and hey, what's going on, girl? I hear that we're not doing as good as we wanted to. what's up? And so I'm actually excited about learning. Like, okay, let's do something different, and let's get you to as happy as I'm going to get you, which may only be 84% happy, as I say, but I'm okay with that, And so those are all things that I've learned. I know we're a little over time, but I just think it was such a good pearl, from both those cases. It's real world, and I hope that the listeners, can learn something from it. Kathy, thanks so much for hopping on and talking to us.
It's always a pleasure. You guys are the best. And I just love watching you guys become like these master surgeons, communicators, citizens, people, friends, husbands, parents, all the great things that you guys do. You're amazing. And I just love you both.
Well, thank you. It's on the shoulders of giants upon which we stand, just like you. And so we couldn't do this without the folks who have taught us the way and shown us how to do it. So with that being said, this is Ophthalmology Off the Grid. Until next time, thank you.
Thank you for listening to Ophthalmology Off the Grid. And thank you to our guest, Dr. Cathleen McCabe, for sharing not one, but two surgical horror stories. Tune in next time